Yeah, this is true. That's why I always ask if I've missed anybody, because sometimes people log in under different names or accounts. The waiting room is still clearing out a little bit. Every time I get it clear, we get more people, which is a good thing. Dr. Schuster, are you on? She usually turns her camera on when she's here.
Aaron, I sent her a text.
Thank you. I was just getting ready to send her an email, but that would probably, she'll see that, I'd say first. If she's not on in the next few minutes, do you want to go ahead and start in the, I'm gonna link the agenda today.
Yes, I think we should. But I have Eddie Reynolds and myself. Are there other members on?
TJ logged
Okay.
in.
Didn't see him.
I think as of right now, you do not have a
There's
quorum.
TJ.
We'll give her just another minute longer, and then if she doesn't log in, we'll go ahead and move forward. And if you do establish a quorum, I can butt in and let you guys know.
I'm on. I can't get my name to show up.
There she is.
Yeah, I'm sorry about that. And Mary Haas just called. She thought the meeting was in person. So she's in room 125 of the Capitol Annex. But she is going to get her computer and log on here in just a minute. So we have Steve and TJ.
Eddie Reynolds is on.
Eddie Reynolds is on. So actually we've got a quorum. If Eddie's on, that's our 4.
We do now. Sheila, Dr. Schuster, do you mind if I butt in for just a moment? This is Erin.
Yeah.
We have been giving all the tax-friendly reminders that all voting members must have their camera on while voting. And to also, the court reporter's been having a hard time with people kind of talking over top of each other and capturing what's said. So we're just reminding everybody to use the raise your hand, try to wait with questions, just so that we can make sure we're capturing the transcript properly. So I just want to throw that out there, and I appreciate you letting me do that, and I will turn it back over to you.
Thank you. And those are good reminders. Thank you very much, Erin, and welcome back.
Thank you.
And I hope you and your baby are doing well. And your
We
whole
are,
family.
thank you.
Good.
We are, thank you.
So if Eddie is on and TJ, Steve Shannon and me, so that's 4 out of 7. We knew that Valerie Mudd is at the peer support specialist recognition event today, and Mike Berry was out of town. So, and Mary will log on, so we'll have actually 5 out of our 7. So we will go on and call the meeting to order. Just a couple minutes late. Thank you all for your patience. This is the Behavioral Health Technical Advisory Committee meeting of May 11th, 2023. And I'm Sheila Schuster, the chair of the TAC. Steve, would you introduce yourself, please?
Yeah, Steve Shannon was CARP Association 1214 Mental Health Center.
And TJ?
Good morning, TJ Litific, representing NAMI, Kentucky.
Thank you. And I'm sorry.
I said good afternoon, rather.
Oh, good afternoon. Yeah, I wondered what time zone you were in, but we're all in kind of the Ethernet here. And Eddie, please.
Eddie Reynolds with the Brain Injury Alliance of Kentucky.
Great. Thank you so much. So those are our voting members. And when Mary gets on, we will have her identify herself.
Sheila, I should be on.
Oh, okay. There you are. Yes, I see you. Great. Mary. That's great. So we have 5 of our 7 members. Thank you so much. So I sent out the draft minutes of our March 9th Behavioral Health TAC meeting, and would entertain a motion from one of our voting members for approval of the minutes.
So moved, Steve Shannon.
And a second, please.
Mary
Second.
Hassel, second.
All right. Are there any questions, corrections, omissions, revisions? If not, I'll call for a vote of the to approve the minutes as distributed. All in favor, signify by saying aye.
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 And opposed, like sign, and abstentions. Great. Thank you very much. We'll have that out of the way. We are anxious to get an update from the Kentucky Hospital Association about the provider credentialing. And I'm very pleased to have Mr. John Copley, an old friend of ours. I should say a longstanding friend of ours. I won't call you old, John, to make that report. So the floor is yours.
Thank you, Sheila, or Dr. Schuster. I don't want to say the
Yeah,
wrong.
Sheila, that's fine. I answered almost anything.
Can you hear me?
Yes.
Okay, I thought so. No, I appreciate the warm introduction. I was flipping through all the names. It's great to see so many familiar faces from at least four former employers and 2 or 3 different boards. And it's always good to see my friend Steve Shannon and you. So thank you for the warm introduction. Good afternoon, behavioral health TAC members, other invited guests. My name is John Copley. I'm the Senior Vice President of Strategy and Operations at the Kentucky Hospital Association. I appreciate the opportunity to provide you an update today on the Credentialing Alliance. Right now, we're finalizing the modernization of the current setup. It is live, but it's not where we want it to be in Kentucky just yet. So we're finishing a modernization of that, so it truly is the CBO as intended in the legislation that KHA and the MCOs previously worked on with Representative Fleming. There's a lot of nuances around how this is implemented in other states that we've worked through. To that end, I do want to thank our partner Verisys and Justin Guilford and Laura Malloy in particular with them. They have been excellent in working with us to customize this to what we need for Kentucky. We expect at some point in July, August at the latest, to be fully functioning with the 3 largest MCOs, WellCare of Kentucky, Passport Health Plan by Molina Healthcare, and Aetna Better Health of Kentucky, who also administers the SKY program. This will include something this group has requested in the past, a universal one-stop form for the process. We'll also be rolling out electronic options in lieu of paper for folks that want those, and a clear appeals process. I also want to thank DMS Senior Deputy Commissioner Veronica Judy Cecil. She's been a great support as we've worked through customizing this process, along with the 3 largest MCO CEOs, Corey Ewing at WellCare, Ryan Sadler at Molina Passport, and Paige Franklin Makovich with Aetna. Those 3 CEOs KHA President Nancy Galvani, who this is her baby, and myself have all worked together, the five of us, to move this where we're right here on the verge of realizing what the best case scenario for providers and MCOs and what we wanted for a long time. So just be patient with us another 60 days, 90 days here. And we'll be where what the legislation intent was. Now, there was legislation in this past session, Senate Bill 209, a late amendment from the speaker that came from conversations, I think, with us and others. We appreciate the importance of all 6 MCOs, all MCOs being included in the Credentialing Alliance, being spelled out more definitively. To that end, I'm pleased to announce another name that I think will be familiar to many of you, that Rosamond Dolan joined the KHA team just this week as Associate Vice President of Payer Relations and Health Finance Policy. Rosamond has an extensive payer-related legal, compliance, and operations background. She's a former executive director of the Kentucky Association of Health Plans, is very familiar with credentialing alliances, and has a close professional relationship with Verisys. So we'll be looking at her to work with Humana, Anthem, and United to join KHA, WellCare, Molina, and Aetna, so we can fully implement the new provisions from Senate Bill 209 by the end of the calendar year as prescribed, which was the intent of the legislation and the only practical outcome. So like I said, hang in there another 60, 90 days. We will be fully up and running with the 3 largest MCOs, with adding the other 3 by the end of the calendar year. And Sheila, that's my update. I'm happy to take any questions at this time.
Great, that's very encouraging. We have, as you know, been eagerly awaiting this, John, and you know, each step of the process. Let me open it up both to voting members of the TAC and any of our participants, if anyone wants to ask a question. And I guess raise your hand, although I'll have to ask Aaron to call on you as I can't see everybody. Is that workable, Aaron, for you to do that?
Absolutely.
Okay. So if anybody has a question for John. While we're waiting to see John, I am trying to recall, because we had some pretty in-depth questions about this when it was first presented several months ago to the BHTAC. And I think one of the questions was, if a provider wants to be credentialed by, let's say, all 3, WellCare, Passport, and Aetna, there still is an individual process with each one. Is that right?
For contracting.
For contracting. Okay.
One of the things we've run into when I'm mentioning modernizing and how's it rolled out in other states is, as you just described, it's really been functioning as both the central CBO, but then also individual. And it really is supposed to be centralized for the credentialing part. And then the MCO makes a decision around a network contract. So when this is up and running, right, the credentialing will be centralized as one. And then the network contracting decision will be up to each MCO and the provider.
Okay, so if a brand new provider, let's say, comes into Kentucky and somebody says you need to get credentialed, and here's the way to do it with at least 3, go to wherever this is housed, to KJ or wherever. Yes. And they fill out that credentialing form. Does it go to all 3 of your contracted MCOs at that point?
So when the process is fully up and running, what we'll do, it will go to the Verisys will then credential or make a credentialing decision, if you will, the file, and then they will notify the 3 MCOs relative, or the 6 MCOs, for a decision, which is why it's extremely important that all 6 MCOs, the speaker and others, realize that for this to truly work as the original legislation intended, all MCOs need to be in. But yes, that is the intent, that there's one decision, it's communicated to those MCOs, and then they know that that provider is available to be in their network or not be in their network, if you will.
Okay. So yes, I would certainly encourage, and I encourage those other MCOs that are not currently in, we will certainly applaud you getting involved and getting in, because I think this is supposed to be a one-stop shop, John, right?
Yes, ma'am.
People
Yep.
don't have to duplicate that credentialing process over and over again, 4 or 5 or 6 times. Yeah. Are there any questions then? Any other questions from anyone?
I don't see any hands raised.
All right, thank you, Erin. I guess, John, my last question, we always ask this. How will we know when it's completely modernized and is ready to go? Will you send me send over a white celebratory flag and I'll let everybody know? Or I'm sure that the MCOs will let people know, but
I think there's a commercial out there right now with that pigeon flying or whatever. I still haven't figured out what that's about, but no, we'll shout it from the rooftops, over communicate, make sure everyone understands what's going on. Like I said, then you have, people with, my background and now Rosalind Dolan background here. So we'll definitely be in touch with all the right people. And Rosalind and I both will be back at your next meeting, and it looks like it's July 13th there on the agenda.
Right.
So I'll make sure to note that.
oh, that would be great. If you could give us kind of a,
Yeah.
Here's where we are now, and we're thinking it's going to be July 13th or sometime, that would be great. All right. Seeing no further questions, I sure appreciate it. It's great to see you, and you certainly are invited to stay for the rest of the meeting if you would like to do so.
But before I go, can I give a quick commercial on the Kentucky Hospital Association convention next week? Do you allow me that?
Yes, we'll allow you that.
Thank you. All right, so the Kentucky Hospital Association convention is in Lexington next Tuesday and Wednesday at the Central Bank Center. Key topics include worker safety, quality, workforce development, leadership. There are tracks around nursing, finance, legal. And on Wednesday, the day after the primary election, we're going to have KSR's Matt Jones and Run Switch's Scott Jennings on for a lunch to do a friendly debate over the upcoming elections this fall, and I'm sure presidential things and those kind of things as well. I believe many of you all know Claire Aran on our team. She's worked with a lot of folks. She's in charge of the convention this year and has done a fabulous job. We have a record number of registrants. Both the Hyatt and the Hilton are sold out. So if you'd like to attend Tuesday or Wednesday or both as a late registrant at a commuter rate, if you send me an email at jcopley, JCOPLEY at kyha.com, I'll get you taken care of, get you a reduced rate. If you want to come on in next Monday or Tuesday. And then finally, and I know you'll appreciate this, Sheila. So speaking of the election, Kentucky has an early, no excuse voting law in effect. So I voted this morning. I got the sticker here to prove it. So vote early this week. Come to the KHA convention next week. All right. So thank you all again. I appreciate it. Always a pleasure to see you.
Yeah. And John, is the convention Tuesday, Wednesday, or Monday and Tuesday?
It's a soft start on Monday with some ACHE, but the guts of it's Tuesday and Wednesday.
Tuesday and Wednesday. Okay,
Yes,
wonderful. Thank you. I think Medicaid Tech chatted. If you'll send a flyer, they'll also send that out. If you
All right,
can
that's awesome.
do that. Okay. Thank you
Thank you.
so much. I appreciate it.
Thank you.
There's the address, John, aaron.vickers@ky.gov for a flyer and your email address. We have a couple of new business items, and I'm not sure if anybody who's on from Medicaid, but there was a request made at our March meeting, and it's in the minutes, that we have a presentation on the Medicaid unwinding, on what the process is with the recertifications, and any other changes related to the end of the federal public health emergency period. So I don't know who we might have on for Medicaid. I think Deputy Commissioner Veronica Judy Cecil has been giving those presentations, but I don't know.
Sheila, I'm not sure if she's on today. This is Leslie, and I apologize. I'm in my car at a conference, but we can definitely get that done. It's the same presentation we've been giving at the MCO forums, so we can definitely get that presentation out to you, and then we can do something special if you want to. We can have a special meeting or come back to the next one, but you might want us to go ahead and get that information out since, there's some folks that might be affected in the next couple of months.
Yeah, absolutely. Leslie, that would be great if you could
Yeah.
send out the presentation, and then I could ask people to let me know if they want to have a special meeting where Veronica or somebody else from
Yeah.
Medicaid. I know people have been very, very positive about the presentation that she has given to several groups. And this is
There's one or two.
issue.
Yes, it's a huge undertaking, and she's tried every way in the world the team has to ensure that nobody gets left behind, for lack of better words. So there's one or two pages that are very specific about things that you need to do, like right now, like get on, establish, check your addresses, establish your an account. That way you'll get all the information that you'll need and get reminders and things like that. So we can flag those particular pages in her PowerPoint, but the PowerPoint's complete. We just got to pull it out of our MCO forms that she's been doing.
Okay, that would be great. Thank you. The other one was in reference to a comment that Commissioner Lee made at our last meeting about the 2020 annual report. And I wasn't sure, Leslie, where that's posted. She had encouraged everyone on the tax, not just our TAC, but I think the tax, to look at that. And I think you all are already working on your 2021 annual report. So can you tell me where that report is?
Yeah,
listed?
Aaron, would you mind? Would you mind
this
to
is
follow up?
Angela. Real
Okay.
quick before we move on to the next one, Beth Fisher, this is Angela with DMS. Beth Fisher put some good information in the chat regarding the unwinding. So again, it looks like there are already some additional meetings scheduled. Again, to keep that information in the public and ongoing. And so she dropped some information there that might be helpful to make sure everybody sees that. And that you again can go ahead and register for those forums.
Thank you, Angela. Thank
You're
you.
welcome. Before we
I
move
couldn't
on.
see that on my phone.
Yeah, thank you. And
And I also have a copy of the presentation that Veronica gave to the primary care TAC that I can also send out right after the meeting, Dr. Schuster.
oh, okay.
And I will also send the email or the website address that Beth put in the chat. So you guys have that as well.
All right, great. If you'll get that to me right after the meeting, Aaron, that would be wonderful. And then I can send that out to everyone that I have on my list anyway. And let me remind anyone who's on this, who doesn't get regular agendas and reminders of this meeting to, if you'll simply email me at kyadvocacy@gmail.com, I'm happy to add you to my list. Aaron does a great job of getting it out to DMS and DBH and the MCOs, but I keep a list of anyone who's participated in the past and is interested in staying attuned to that. So that's great. Since we're on new business, I know that we have a pressing issue, and Angela, I know that you're on. I think David Sussman from DBH is on. Is Tracy Horton on?
Yes.
Okay, Tracy, do you want to describe this issue under new business that we talked about, and we've alerted DMS and DBH that this issue is coming up?
Okay. We have received an audit from one of the managed care companies. And in that audit, they're specifically looking at case management and have determined that based on the regulation, that case management requires a separate care plan. And unfortunately, what we have determined based on how the guidance came from DBH DID several years ago, this is in direct conflict with how our system is configured. Our system is configured to have a integrated care plan. And so my concern is that, this has been in place. The current system has been in place many years, and that the new interpretation of separate care plan and what the MCOs or what this particular MCO is saying is leading to a significant recoupment from our standing. And just to have some concerns that, you know, if the guidance from the department was one thing, that we're not all on the same page. And that, you know, if this guidance is changing based on the interpretation from this MCO, there needs to be some communication from the department, and there needs to be some point in the future that this is corrected and allowed, you know, to move forward. You can't go in and arbitrarily determine that a regulation is being interpreted differently and start recouping based on that, in conflict with how the state has provided guidance since 2016.
All right. And my understanding also, Tracy, is that particularly for CMHC such as yourself that have a electronic health record system, that it's extremely difficult or impossible actually to have multiple care plans in there.
I have been told that it complicates the process. I won't say that it's not doable, but it might necessitate costly changes with our software vendor to ensure that we have that capability.
Yeah.
But I think, you know, my concern is just that, you know, we're talking about a significant recoupment without any prior notification that, you know, their interpretation had changed, and that it potentially could open the door for this, you know, other interpretations and, you know, massive paybacks from our agency when we actually have care plans. We have everything that we need. It just doesn't meet the format that they've determined now is, you know, their new interpretation.
Okay, thank you.
I know if people have their hands up, I'm going to weigh in, Sheila. One, I've heard repeatedly that the electronic health record, 2 plans, if not, it's not prohibited, but it's just, it's, you know, you have 2 sets of data searches, you got to get different information, you got to pay people to do that. It's just not feasible. And secondarily, and I think and more significantly so, is the regulation languages of development and periodic revision of a specific care plan for the recipient. Now it's a TCM, but it says specific care plan. It does not differentiate overall plan, target case management plan. I think the specific, that word applies to the recipient and not the care plan. And why would we not want to have specific care plans for recipients as opposed to a specific care plan for case management? The regulation also references medical, social, educational, and other services. Is the expectation a care plan for medical, for social, for educational, or other services? I don't think that's the case. I think clearly an integrated care plan is the approach that we want to move forward on. And this is an interpretation, and it's a regulation. It's open to interpretation, but I don't think anyone can take action on a recoupment based on their interpretation. And I will continue to report CMS issued guidance on reentry from correctional facilities. I am on that TAC. Their case management language doesn't specify a distinct plan. It's a comprehensive plan. I don't think CMS's intent is to have a specific targeted case management plan. I think the plan is we want to have a specific care plan for the recipient, not a specific care plan for the service. And I think the distinction is if you have a targeted case management plan specific to that, does a plan that says we shall have 4 contacts per month meet that standard of a specific care plan for targeted case management? That's not a good care plan. It's for the individual. I'm really frustrated this has come up. I really think we talked last month about targeted case management and the cost benefit analysis was clear. And now we have this issue. I think this is just an overreach of the interpretation. And I know DBH and DMS are going to look at it, but I don't believe the regulation, you can hang your hat on a distinct plan for case management. I just don't see it. And at best, you could argue it's neutral to it. You can't recoup on neutral.
And Steve, this reg has been in effect, remind me, 2015?
2015. So it'd be 8 years.
Yeah.
Of targeted case management based on this interpretation, and those are dollars going back, both state match and federal match. it's almost a random action, in my opinion.
Kathy has her hand raised.
Yeah, and Kathy Adams from the Children's Alliance has her hand raised. Kathy?
Thanks, Sheila. This is a huge issue for our members as well. And we have actually reached out to the secretary and commissioner and raised our concerns. I echo exactly what Tracy has said and Steve has said. We are in complete agreement that we support an integrated care plan. We disagree with the new interpretation from the regulation and believe that specific care plan does not indicate a separate case plan, that those are not the same thing. And we are very concerned. We feel like this is something that needs a response soon because we're very concerned, our members are very concerned that other managed care companies will take the same interpretation and that members will be facing even more takebacks than the one MCO that is taking this interpretation now. And we also have at least one member that is facing takebacks from the one MCO for this very reason. So again, we represent multiple behavioral health service organizations and behavioral health multi-specialty groups and wanted to weigh in that this is a huge issue for us as well.
Did you get any response back from communication with Secretary Friedlander or Commissioner Lee?
Yes, I do know that Commissioner Lee and our president, Michelle Sanborn, have had some dialogue. And I do believe Michelle is on the meeting if she wants to chime in and add anything.
Commissioner Lee just said that their interpretation hadn't changed. And that she was looking into that. I sent another reminder about this week to her. That was several weeks ago when we had that exchange. I sent a reminder saying that we would be talking about it today. So I really don't have anything, but I don't know when they say it hasn't changed. We got feedback from DMS. DMS had indicated that it was separate is what specific meant. And so we, of course, again, are advocating that we only have one integrated care plan, but if the interpretation is separate, that we change the reg to say separate and we allow providers to have 6 months at least while the reg is being changed to get their systems in order to do separate. But we don't know of any other state that requires a separate plan, even though we know this specific language is actually federal language. And so we know we're following federal laws with specific, but there are several agencies who provide care in many other states, and none of them have a separate care plan for this.
Okay, that's very helpful, Michelle. Thank you. And Bart Baldwin has his hand up.
Yeah, thank you, Sheila. Just as someone who represents different provider groups, just wanted to say ditto to all this. I think that this type of change could just wreak havoc, to say the least, on the TCM services provided to the Medicaid members across the state. So I just want to reinforce what my colleagues are saying, that this is something that if it hasn't changed, then we need to stop this. But if we're going to change this interpretation, then it needs to be through the formal regulatory process.
Okay, thank you. And Dr. David Sussman, Special Advisor to DBH-DID.
Thank you. I wanted to add, I guess, more of a process comment, which is, over a number of years, the migration to an integrated, comprehensive, person-centered recovery plan is our best practices. And so, that plan includes all aspects of an individual's care. And that train's left the station a long time ago, and we're not going back to having 9 separate plans for people's care. So just, thinking about what our best practices are.
And I think that's what I'm hearing from the providers that are being represented here, David, is that everybody's talking in terms of an integrated care plan for the individual, not specific to even the kind of service that's being rendered, but that all of it is geared toward helping that individual in all aspects that are appropriate for the provider to focus on. So that's very helpful.
And if the interpretation is it is a specific care plan, that ought to have been shared prior to 8 years. Right? I mean, that's the real message. And the regulation was effective. This was April 3rd, 2015.
Yeah.
So 8 years and 1 month ago, this was in effect, went through the process. And now we're hearing the last 45, 60 days, Tracy, that we need and what's going to happen is, and I will tell folks, you need to have a targeted case management plan that says 4 contacts per month. It doesn't say what the plan has to be if it has to be specific. And that's not good service, is it, Dr. Sussman? We're just going to play a game to placate an issue that's been raised. I think it doesn't meet people's needs. In a past life, I spent a lot of time in Somerset, and the Department of Justice, United States Department of Justice, wanted an integrated care plan. And if you didn't do it, they're going to sue you. That's what they want. And now we're going to say, no, we're going to have this standalone plan. And we'll go back to a recreation plan, right? And they're all separate, and the poor individual talk to 600 people and be more confused, less access. It's not better services. It's not better. Yeah. And I think if nothing else, this group wants better services, not more plans. So my recommendation would be better services.
Yeah.
If I may, I can read you. It says, while targeted case management services should be identified in a recipient's overall treatment plan, along with all other services being provided to the member, there must be a care plan specific to targeted case management services to meet regulatory requirements.
Where is that?
That was in our letter, our recoupment letter.
Okay. But I still look at the regulation.
Yeah.
Develop a periodic revision of a specific care plan for the recipient. If there's a conflict within the regulation, that needs to be resolved.
Angela, are you on to represent DMS on this issue?
Sheila, I'm still on. If I could just take this one.
Yes, absolutely, Leslie,
Commissioner Craycraft and I have already met more than once about this, and she's here with me today at this conference. So we want to take this back. As you're aware, we were just made known of the situation recently. I know Tracy's in a little bit different situation than the fear of others, but just know that we're going to take a look at it. We've been on this tour and we just haven't had a chance to have 2 seconds in the office to address it. So I know, and I don't take Tracy's situation lightly, and I understand that. So just let us take this back and let us work through it. We have not made any changes. We have not made any changes. So if it's DMS language, then we need to take a look at it at the guidance or the language to make guidance, if that makes any sense. So just give us a little bit of time. Again, I know Tracy's situation is different, but we need to all get back into the office and be able to talk about it just a few minutes. Okay.
Yeah, let me ask you the 2 questions, Leslie, and of course we're happy that DBH and DMS are going to talk about this, because I think there had been some training, as Tracy relayed to me, by DBH originally about how the care plan should be constructed and so forth, and Adanta as well as other providers. I think we're following that guidance as I recall. can you give us any kind of time frame, and what would be the process of your at least letting me know so we can let people know? That's number one. And number two, for someone like Tracy who has this recoupment letter, is there some way, and I don't know enough about recoupment, so I may be asking a question that doesn't make any sense, but is there any way to stop the clock on this if there's some kind of penalty or whatever until it's resolved?
I think that we could probably, Dr. Schuster, find time to get together next week. We've been on the road with the MCO tours, and then today was the Children's Mental Health Acceptance Day, so we're all here today. So I would hope I can get together sometime next week and have a discussion. And that's, again, I don't want to sound just so flighty to you, but I was hoping that we could not talk about this today until we could get some answers for you, because I like to try to resolve your situations.
Well, I think since we were having the meeting and there were so many people affected, I think one of the things we've tried to do is to create a forum at the BH TAC for people to bring up these kinds of situations and to use it as a way to let DMS or DBH or the formulary people or whoever, wherever the problems are, kind of know what's being experienced on the ground. So we're not, don't hear us as being negative towards you at all. We're just concerned for sure. And I think individuals coming to you all, has been helpful, but this brings the collective voices together. So that's why I took advantage of the fact that we were having a meeting today.
It's okay. It's okay. So like I said, give us some, go ahead, Steve. I'm sorry.
I think it's fair for the recoupment be held in abeyance till this is resolved.
I've
Again,
asked
I'm going to have to
a
take a
pending
look at it.
status. I've asked them to pend it because, at this point they've indicated we can appeal it again, and we've taken those steps to appeal it. But I've also asked, in light of the second appeal and the ongoing communication that we're having with the state, that, it be put in a pending status moving forward, because otherwise if they don't have a response by May 19th, they're going to recoup thousands of dollars.
This is Kathy Adams. I just wanted to add that our member that is facing recoupments, they have appealed this with the MCO. So hopefully that will give them a little bit more time. But again, it is a little bit urgent. So we appreciate DMS's prompt attention to this. Thank you so much.
And I believe it's my understanding that Aetna sent something out to their network talking about this and asking their providers to do a separate one.
That's correct, Michelle.
Okay.
And I have a copy of that correspondence if Sheila needs it.
Yeah, that would be helpful because I have not seen that. And I don't know if DMS has seen it. Are you aware of that, Leslie?
I don't think I've seen a letter. I've seen the emails that have been going back and forth related to the recoupment. And then I think Stephanie Craycraft sent out an email just that we were going to go back and work on this together.
Well, I'm concerned that Aetna has gone on and sent out a letter to their providers saying this is what needs to happen, when we're not at all sure that that's what needs to happen. Kathy, why don't you, if you would,
I was going to say somebody forward that,
Leslie as well. You're on mute, Kathy.
I will send it to you, and then Angela Sparrow and
Leslie Hoffman.
Leslie. Okay. I sure will.
And send it, you could send it to David Sussman as well. So DBH is in the loop.
All right.
That would be very helpful, because I am concerned about it going out, and providers who don't know the background saying, oh my gosh, now we got to do this completely differently. And as Dr. Sussman pointed out, this is really a huge step backwards in terms of quality of care. We're dealing with very complex folks who need case management. We already have talked about that. We have the data, from multiple studies now about the importance of it. And I am concerned about this going out to providers. Nina Eisner has her hand up.
Which MCO are we, hold on, let me get off. Which MCO are we talking about?
It's Aetna.
Aetna. Okay, thank you.
And so far, Nina, as far as we know, that's the only one that has made this interpretation.
Thank you.
Yeah. Since we're talking about targeted case management, there's a little side issue that has come up under new business. Bart Baldwin, do you want to bring that up, please?
Sure. Thanks, Sheila. Just one of the pieces as part of the unwinding of the public health emergency, TCM has been allowed to utilize telehealth for some of those visits throughout this time period. It's our understanding that obviously the use of telehealth in lieu of in-person has been extended as part of the legislation and Medicaid decisions moving forward. But we just want to be sure that that is, but again, I think it's a regulatory piece. The TCM regulation itself hasn't been updated to say that can be done. And so I keep hearing from providers that there's concern that on one hand, they continue to use telehealth because we still have some folks that, either it's remote to get to, beneficial to access them remotely, or some of the individuals, I know today's the day the public health emergency ends, but we all know that COVID is still real and still out there, and people still have safety concerns. And so there's some clients that would prefer to continue to do these things virtually. And so I just keep hearing from providers that they're concerned after today that they will be get recoupments for that reason, or claims denied for that reason. So just seeking clarification on that. When I've asked that, it's just been stated that yes, telehealth has been extended, which is great. I just want to be sure that that's clear.
What does that mean?
Yeah, yeah. So does that make sense what I'm asking, Dr. Schuster? Yeah, Steve,
Yeah.
thanks.
Yeah.
So Dr. Schuster, currently right now, there's no thoughts about changing anything related to telehealth. CMS, the federal government, will make some changes possibly related to the platform that we use. The platform has been extended, I think, through August. And then there was also some conversations in the federal world related to audio only. They accept audio only, but in the future they may ask for audio and visual. So I can think of right now.
And
Well-
Leslie, sorry, this is Angela. Again, with the passage of House Bill 140 and DMS telehealth regulation, again, the services that allowed the flexibilities under the public health emergency to continue once the public health emergency ends. So I think that was part of the discussion on the agenda item number 10. TCM falls in with all of the other behavioral health services mentioned there. Like Leslie stated, with the passage of that, there are no changes once the public health emergency ends. That bill and that regulation allows those services to still be carried out as long as they meet the allowance under that telehealth regulation, being that there's no restrictions in an individual, the licensure boards, or again, any of the coding. There's no restrictions on any of those services under the national coding procedures or anything like that. So again, those are continue to be carried out.
Okay, I'm sorry, I had to step away for a minute. Bart, does that answer your question? Does that give you what you need?
I think so.
Yeah, I think it sounds like carry on as we've been doing things for the last 3 years. So that was
So-
about what I heard. Yeah.
It depends on what your definition of carrying on is. No, I'm just.
And we realize again that over time, we will need to update the regulations to align with the telehealth regulation.
Right.
The language around face-to-face and in person. But again, the telehealth reg supersedes those other, the behavioral health
Okay.
regs in terms of that language at this time.
Okay. That helps. Thank you, Angela.
You're welcome.
This is Leslie. I was going to mention too, sorry, I lost service just for like 2 seconds. So you might have already said this, Angela. Commissioner Lee had also mentioned that there's a lot of conversations in the federal world related to the current platforms that may not be considered HIPAA compliant right now might be able to get HIPAA compliant by the time that the platform rules come out from CMS. So currently right now, Facebook or I'm not Facebook, but FaceTime might not be allowed. But if FaceTime is able to get into compliance, I'm just saying FaceTime or, Teams or Zoom or whatever the platform is that CMS ends up approving federally, we've heard that that those larger companies are trying to get into compliance.
Oh, okay. That would be good news, I think, as well. That's very helpful. And we have one other item of new, well, let me make sure. Any other questions about, the interface between telehealth and the TCM issue?
Sheila, this is Angela again. I'm
Yeah.
just gonna put a reminder on the telehealth regulation. Again, that's 907 KAR 3 semicolon 170. And so again, the services need to meet the telehealth
Yeah, thank you.
regulation.
And we have sent those out in the past. If somebody wants them again, you can email me. We had actually, I think it was Jonathan Scott presented to our BH TAC. I want to say, Angela, maybe back in November. I've kind of lost track of time, but when they were issued and went through them in great detail, and that was very helpful. I think actually, don't you all have an FAQ about the telehealth reg? Yeah. And you've just put the reg in there, 907 KAR 3 170. There's also an FAQ document that was created that I think is very helpful to go along with the reg, because the regs are not always easy to read and understand and so forth. So thank you very much for that. Kathy Adams, I think you had a question about the BH behavioral health fee schedule. Yeah.
Right. Thanks, Sheila. So I believe at the last MAC meeting, the commissioner brought up the behavioral health TAC, the possibility of the behavioral health TAC, looking at some of the most used codes or the most important codes when it comes to behavioral health services, simply because DMS doesn't have the money to provide across the board rate increases for everybody, but that they might have some money to increase specific codes or slash services. And so the Children's Alliance has been working with some of our members on that, but I guess it was day before yesterday at the Administrative Regulation Review Subcommittee, Commissioner Lee spoke, was addressing some of the legislators' concerns about 3 regulations. And she indicated that that Medicaid is doing a behavioral health rate study. And this was news to me, and as well as when I reached out to Sheila. So we were just wondering if there's any update or any information that can be shared on the behavioral health rate study that Medicaid is doing. And Commissioner Lee also indicated that there was a special focus on children's behavioral health services as well.
This is Leslie. I'll have to ask if Angela knows anything specific too. I know we've been taking a look at just about all the rates. We can't do across the board, but we are trying to look at specific things that we can make a change to, or maybe state specific codes as well. I do know that that's in the mix. Ann Holland has actually been working on that. Angela, do you have any more information?
I don't, I'm sorry. But we can definitely take it back and ask.
Yeah, I think it would be helpful because I really heard the commissioner at the last MAC meeting, which would have been at the end of March, kind of making that blanket request of all of the TACs to look at their codes and look at the ones that perhaps are the most useful or the most frequently used, or whatever criteria, to point out some that would really be helpful if they were increased. And if DMS is undertaking some kind of behavioral health study, we'd sure like to know about that before we spend a lot of time looking at codes and so forth. So any information that you all can get back to us to let us know, I would tentatively put that topic on our July TAC meeting agenda, just to get a discussion going. But I think the other thing that she, suggested, and I don't know how this would work with our provider groups, but to do something similar to what the hospitals have done,
Right.
in terms of putting up their share of the match to get increased rates. And, I see a big difference between what the hospitals have to offer in that regard and what most behavioral health providers have, but maybe there's some room to look and be creative there as well. Obviously, if the state is not responsible for the state match, but it's coming from someplace else, then you've got some money to work with to get the match on increased rates and maybe additional services and so forth. And Steve, I know that you've looked at that over the years.
Yep. Yeah, she said at the MAC meeting visually, look at codes to increase reimbursement as a more strategic approach.
Yeah. So if Leslie and Angela, if you could give us some feedback about where DMS is in that, that would be helpful. And I think Jonathan Scott has shared some information in the chat as well on those issues, but we will certainly look at that. So lots of new business. The next item I have on here is a very specific and very loud thank you to DMS for the recent and quick recommendations on billing for extended services, like the extended length of behavioral health services. We had a lot of providers who were seeing some high need patients who were really suffering when those extended length sessions were not available. And we are certainly very grateful for the quick work around that and proposing a kind of workaround with an additional code, and also posting the BHSO reimbursement rates. I also would like to especially thank Leslie and Kelly Gunning. Couldn't be on the meeting today because of their activities today and tomorrow around peer support and so forth. But she wanted me to share that we had a Medicaid member who was a long time substance use user, also had co-occurring mental health issues. I think came to the attention of their mental health court, and they were working with him, and he had really turned the corner in his recovery process. And then there was a glitch and he lost his Medicaid coverage and couldn't get his medications. And Kelly reached out to me and I reached out to Leslie and Leslie worked whatever magic that is that she and those of you at DMS are able to do sometimes. And we got this guy back on his medications before he relapsed and had some other physical health and behavioral health issues. So in fact, Leslie reached out and asked, for kind of an update, and the update was so positive. I just wanted to share with you all that this guy had apparently a longtime girlfriend who had stuck with him through thick and thin, through some very tough times, and had said to him if he ever got, into recovery and was really making progress, that she would marry him. And so they got married. And he's happy as can be, and she's happy, and he's in recovery. And, so it takes a team. Like they say, it takes a village to raise a kid. It certainly takes a team of people, but I think it's a good example. And I do particularly want to thank you, Leslie, and others from DMS and DBH who, are able to work your magic and fix some of these things. But I think it's that teamwork of those of us who are at the ground level and know what's going on and, get the information up to people that can do something about it. So I thank you very much for that. I don't know if Justin Derringer is on. I wondered about the status of the website dashboard.
Yes, ma'am. Thank you.
Oh, great.
Justin.
Nice to see you, Justin. What's our status?
Well, so we had originally decided or had a November. I'm sorry, not November. It will probably seems like it's going to be November. We had originally had an April release date scheduled. We received notification that had been bumped due to the unwinding, and some of our IT staff that were working on finalizing that dashboard got pulled into the unwinding updates. So we're hoping for June. That's the goal. But I'm keep pushing, and as soon as that's done and complete, you all will be the first ones to know. And in addition to that, I wanted to let you know in particular, because I know this is a topic that we've discussed before. There were some providers at the MCO forums who had talked about creating, using that, the no-show reports that they were going to have access to, but also putting together some suggestions to send in to their respective TACs as providers on ways to assist in decreasing the no-show issue. And I know, as I had discussed at one point in time, that dashboard will be a benefit for us in DMS because it will help providers, show the providers the importance to reach out to members and try to get some type of reasoning. And, even if it's 10% of people, if there's an issue with transportation or there's an issue with understanding, something like that, even if it's a small percentage, if we can get that, at least that's something that we've accomplished. So, but just kind of wanted to let you know where we're at with that. I at least once a week, touch base with our IT staff about where that's at, where their progress is, and trying to get that completed as soon as possible. So as soon as it's done, I will make sure to do a presentation on it and about it and show it to you all, and I'll be very glad and happy. So.
Yes, we will be very glad and happy as well, Justin. Thank you. And thanks for hanging in there and pushing it forward. We would definitely, particularly if it might go live in June, I'll keep this on the agenda for our July meeting. And we would give you some time to walk us through that and how it's being used. I do like the idea of once it's out there and it's more public and more usable, and we have more numbers, trying to identify, at least for the behavioral health clients, what are those social determinants of health, or what are those barriers that we can identify. I know there's some changes being made in non-emergency medical transportation. And I suspect as we go, I'm with a group that goes around to different communities and does kind of a road show on services, and NEMT is always a hot topic at these groups, I'll tell you, with people struggling to get transportation and so forth, but childcare may be another one, and even using telehealth still may be one. So I like your idea of using it to give some feedback to the MCOs and to others about addressing those issues. So appreciate it very much, Justin. Does anybody have any other questions for Justin? Okay, thank you very much. Is Leslie still on? Because the next item is the newly released CMS guidance on waivers.
Sheila, I asked Angela to take this one since I'm in the car on the phone.
Oh,
Angela,
okay.
can you take that one for, it's a little lengthy.
All right, that's fine. I linked together about 6 questions, I think, in this agenda item. So basically, we're looking at this newly released CMS guidance on SUD services and how it might impact our Kentucky's waiver application. The end of the public comment period on the 1115 SMI waiver. Where are we with the 1915I waiver for supported housing and supported employment? And then where are we with the request for extension of the Team Kentucky 1115 waiver? So Angela, take it away, please.
Hi again, Angela Sparrow with DMS. And so if we can, I'm actually going to start with the pending extension request, since that's kind of the overall 1115 authority. And just again, probably the quickest update there, we continue to have our monthly calls and conversations with CMS around the ongoing 1115. We have asked them if there's any questions for Kentucky, any additional information they need from us regarding that pending extension application, and they have not provided us with any additional information at this time. So they know the importance and how pressing it is, but really we just don't have any updates from them. But we continue to ask. So again, they know that the time frame that we're under, and it does look like there are other states that are getting their extension request approved. Again, I know that we're in queue prior to us, so that's promising. But again, it continues to be on the agenda. Regarding the recent guidance from CMS around the reentry demonstration opportunity, again, the disclaimer I keep telling everybody is we still don't have all of the answers. So again, it's very much still an ongoing conversation with CMS as well as the other states that have pending demonstrations. So again, still working closely with them as well. Just kind of a highlight, an overview of the guidance that they released recently. Going through that, Kentucky is going to need to make some changes to our pending application. Our pending application is not going to be approved as is, and that's okay. I think that was anticipated, knowing that there has been quite some time that's elapsed since we initially submitted that. But with that being said, we continue to work with them to determine what is the scope of changes that we would need to make in order to get that approved. And really that's because CMS has definitely given states some flexibilities in that guidance that they issued around covered settings, reentry settings, again, covered services, and how to deliver those services. So again, just some conversations to still be had around moving forward with what was originally submitted, or again, how in-depth of changes we might want to or need to make as we kind of work through if we're already making changes. So really just trying to determine what that might be. But again, in the guidance, CMS has mandated for any of the states that do receive the 1115 opportunity for reentry, there are 3 minimal required services that the states must provide. Number one being case management. If you have seen the guidance or read through the guidance, it is very significant. Again, it is beyond our current targeted case management requirements. And so there's definitely a lot of guidance around that. But again, the goal of that demonstration is really the importance of improving those care transitions for those individuals. And so all of the tasks under the demonstration really have to tie back to that. Another service is medication assisted treatment is required to be offered. And that does include the accompanying therapies for those individuals. And then again, states are required to provide a 30-day supply of all medications, not just related to MAT, at the time that the individual is released. And so those are the 3 required. Again, states have the opportunities and flexibilities to request additional services. They have been upfront with states that may request full state plan coverage, that they are not going to initially approve that. Doesn't mean that a state can't request that, but again, that's not going to be approved upfront. Another thing, again, that they have been very clear about is the pre-release timeframe. So again, states can approve 30 days under the Support Act. Through the demonstration, states can request additional coverage pre-release up to 90 days. Again, any state that requests beyond 30 days up to 90 days has to be able to provide justification why that time frame is needed. Again, to help improve those care transitions, which I think we all agree it can be done. And so, but again, with that being said, they are very clear that the states would not receive any federal match funding prior to or greater than 90 days pre-release. So again, we continue to work with them, our state agencies, and again, we'll be convening some stakeholder, definitely some engagement. They really, through the guidance, put an emphasis on working with individuals with lived experience as the state looks at planning and implementation of these programs. And then again, there's lots of health IT integration requirements, which will be large system changes that we'll have to work very closely with our state agencies and partners to develop to really ensure CMS wants to know that the state has a clear path and plan, that those services again are really coordinated and available immediately upon release. There is some guidance around eligibility of the member for those that might have a short time pre-release date versus those who again maybe have a longer incarceration date, but there definitely have to be some eligibility changes. But again, all promising things. We are excited that states finally have the framework and the guidance to work through. But again, it's great to see and also work with the other states that have pending amendments. But I think every state also is aware that every state is different in their ask and their makeup. So really just working through that. So I'll pause. I'll touch, I guess, briefly on the reinvestment plan that's also required under the demonstration. And again, there's lots of discussion to still be had around the plan and the requirements. And so essentially, any service that the carceral setting is already receiving state funding to provide services for, or again, any of those existing services that might be expanded or enhanced under the demonstration. The state Medicaid agency is required to reinvest the full federal match funding that they receive for those services to new services, or again, there's a wide array of how states can reinvest that funding. States can even include their state dollars for those services as part of their reinvestment plan. It can go towards, again, enhancing and expanding the IT systems. And again, so it doesn't have to be necessarily around new services, but again, how to ensure that those services are delivered. So there's lots of, again, opportunity flexibilities for states. But again, there's still questions and things to be addressed with CMS as well. So
Yeah.
any questions around the incarceration?
Yeah, not so much a question, Angela. You know, we have the Person Returning Society from Incarceration, TAC, the world's longest name, TAC. And we discussed this, and clearly the impression I got there, you know, the guidance requires Kentucky to comply with that. It's not necessarily what was already submitted. It helps, I guess, there's guidance, and they're hoping that the morning it was reported in our meeting, fall to December, maybe, you know, get the work in place and go from there. But, you know, that TAC has been paying attention to this 1115 for a very long time. You know, hoping every month, Leslie says, we hope to hear soon, or every other month that we meet. So we're glad to have guidance, you know, but I think we really are eager to get this started. And part of the thing that we did not include initially was a big emphasis on physical health as well, isn't there? And I asked, you know, there was the 1115 SMI piece that was submitted on IMD and the medical respite. Would these folks be eligible for medical respite? And I think that's a question that's being discussed. And they may be, if they don't have a place with that risk of homelessness, they may be eligible as well for medical respite, kind of tying those things together.
Right. And yes, I think that that's a good point, Stephen. I think that again goes back to, it's exciting, but again, kind of the still trying to navigate the scope of changes that the state needs to make, and the scope of changes that maybe need to occur up front versus to get approval and then amend the demonstration at a later time to grow additional populations, to include additional populations or services or conditions and so forth. And so again, that's because, like you stated, I think, you know, we have been waiting for quite some time for this
Is it 3 years?
Yeah, I think November will be 3 years. So, you know, we do want to act as soon as we can. And again, we will have to make some changes, but CMS has been upfront. It's not like the state has to withdraw what we have submitted. We can amend what we have already submitted. And again, we would still go through another public comment period to make sure stakeholders are aware of what those changes would be. So we're by no means starting over.
Wow.
Definitely not. But yes, there's still some changes that have to occur.
And Kentucky submitted it first, right?
Correct.
So we were first, then California.
Oh, Angela, if I may, so Steve, I think what we're probably going to do is we don't want to pull back what we have. We want to amend it, and so we can get that approved and start moving forward very quickly. And so we've already talked about this. We want to develop kind of a time frame to maybe do some phases or rollouts, and we need a time frame to keep ourselves on track with the times that we want to submit these things. So like Angela talked about, there's a lot of pieces to this, and in the 3 years there's a lot more opportunities that are out there now that weren't out there, and some requirements that we didn't know about. California had been working through a pilot that they had internally for almost 5 years. If you remember, we had a bill that had us to address this to get it out very quickly in about a 90-day time frame. So they worked for a very, very long time on that reinvestment and to justify the 90 days. We're not going to get 90 days just because we want it, but we do feel like we can get more than 30. So I think that's something that we'll take a look at. And don't forget, we have 2 bills out there right now with Moser and Carroll. There's 2 bills, and then the Omnibus Act to take a look at the DJJ individuals who are confined, the youth. So I think we'll probably do some kind of timeline to do a rollout plan.
Yeah, because this includes youth as well, doesn't it? The guidance.
It can.
Yeah.
Yes, California. I think California did, didn't they, Angela? So that's something that's come out since we've submitted that. So those are things that we've got to take a look at. And I think our best bet to start getting something approved now and then build on it. I don't want to develop something for 5 years. I want to get something in that we can get approved and then start on the development in the next phases.
All right. Thank you all. Good work.
Yeah, I was going to ask about the public comment period, and it sounds like that would be a part of the amendment process as well. So very
Excellent.
thorough. Thank you. And the final thing would be the 1115 SMI waiver piece, and then the 1915I waiver piece.
So for updates on the SMI waiver, again, thank you to everyone who submitted public comments on the draft that had been posted, and everybody that attended the forums to review the draft. The public comment period did end last Friday on the May 5th. So we are currently reviewing all of the the comments that we did receive. I think there were a couple handfuls of those or more, which is great. So we're taking a look at those. We will provide response to all of those prior to, and with that being said, based on the public comments, ensure that we make any amendments to the application that is needed prior to submission. So again, still hoping and planning to be able to submit that to CMS by the end of the month. But again, really taking a look at those comments at this time. So everyone who submitted comments should receive a notification, and the responses will be certainly posted to the website for review, and again before the actual submission to CMS. And so that's where we are on the SMI amendment. For the 1915I, I'm going to pause. I'm not sure that Pam Smith was able to join us or not. And if she's not, I'll give an update real quick on that. And so again, just kind of a reminder, I believe this has been mentioned, but regarding the 1915I SPAL submission, DMS again is still considering levels of supported housing in the SPAL package, tendency reports, or again, supportive housing, supported education, supported employment, planned respite, case management, medication management, services in the 1915I SPAL package. I know the team was very grateful again of everyone who participated in those stakeholder meetings. The group is currently reviewing that feedback that was collected through those meetings, and again are working on conducting some strategic design sessions to really narrow the scope of the services and the target populations and definition of those services as they work towards drafting and application, which I believe again that they're still hoping to do early to midsummer. And again, with a public comment period, mid to late summer, with the anticipated submission to CMS, hopefully to follow that. So that's the update on 1959. And again, Leslie, if you have anything else to add on that.
And Angela, did you mention, sorry, I'm going back and forth. Did you mention that we hope to have the public comment out summer and maybe late summer for the CMS? Okay, sorry.
Yeah, no, that's right. I think mid to late summer is the anticipated timeframe.
All right, that sounds very good. Does anybody have any questions? So I guess I'm a little bit confused. The medical respite was in the 1115 waiver amendment. Is it also going to be in the 1915I?
Sorry, Sheila. So the medical respite again is in the 1115 amendment. The plan respite that we spoke about under the 1915I is the behavioral health respite. So again, the behavioral health respite and medical respite are two different services. They target two different populations. The medical respite again is really for those individuals that are
Discharged from the hospital, right?
Yeah,
And
the homeless, correct, the
danger
homeless
of
population.
homelessness. Yeah.
Right.
All right. So the behavioral health respite is what?
It's more of the caregiver, the planned caregiver respite.
Okay. I didn't remember that was part of that.
Sheila, the
Yeah.
recuperative care or the medical respite can only be approved in 1115. That's why it's there.
Okay.
It's the only place that CMS has approved it so far. So we did the
and
best we
that-
could at trying to connect them.
Yeah. Yeah, that's fine. I mean, I think we're all happy to have that service. I didn't remember that there had been a behavioral health respite that would be for caregivers. I mean, I think of that with kids.
Hi, this
That's
is Sherry.
correct.
from-
Sorry,
Oh,
go ahead. Sherry.
sorry, Angela. I was
No.
just gonna jump in, and I think you're exactly right, Dr. Schuster. It would give the opportunity for behavioral health respite for non-DCBS and non-1915C waiver, children primarily. And it might be to stabilize a home placement to prevent further out-of-home services or other possibilities. It does give the caregiver a break, just as any of those other situations would, but it's more for behavioral health type things, to stabilize kids in the community in their own homes.
Okay, so now I'm really confused because, and we keep having this discussion. I thought the 1915I was devoted to adults with SMI.
Dr. Schuster, this is Jody Allen. I'm here with Leslie traveling.
Okay.
So, all right. I would love to answer this question. Okay.
Good.
So for the 1915I, when we're talking about behavioral health respite, we are talking about individuals with SMI that are adults, and it's the planned caregiver respite for individuals with SMI.
And then our SED will address.
And the SED is going to be, we are planning on approaching that through SPA.
What Sherry was.
Yes, and what Sherry was talking
Oh,
about.
okay.
Does that make
All right.
sense?
Yeah, I just got really confused there.
Well,
because
it is
Sorry,
confusing.
It is confusing.
It is, yes. It's very
I
confusing.
was pretty sure it was just me. Okay.
Well, no, I think it's the term respite. That's why we're calling it recuperative care, because respite in all of our minds in Kentucky is a whole different service. So the recuperative care is in the 1115 proposed, and then the 1915I will cover the behavioral health respite, which is planned respite for adults with SMI. At the same time, there are a lot of discussions about the multiple different services that we can include in the 1915I. So there are some other services that could be somewhat overlapping, and we're still in a conversation stage on that, okay, as far as like what exactly in the 1915I will be included. But definitely supportive housing and supportive employment, as was discussed and as we know has been directed by SJR 72.
Okay, great. And Kathy Dobbins from Wellspring has her hand up. Kathy?
Yeah, no, this is great information. But could you define, two questions really. One is, could you define planned respite in just a few sentences? And then secondly, when the 1915I is posted for public comment, could you let Sheila know that so that she could send that out to all of the BH TAC and those of us who participate regularly.
Yes, thank you, Kathy. Of course, we will make sure that notifications are sent to all of the TACs. And so that will happen for the 1959. I'm on the planned work group. And so I'll make sure to communicate that. And then the other thing, as far as what is planned respite, really we're looking for respite of the caregiver who provides the care for the individual who has SMI. So it will be planned in advance.
So there'll be providers offering a new level of care to give the family or whoever the caregiver is a break.
That's what we're looking at. We are looking at how other states are able to provide that. At the same time, anyone who is in residential would not be eligible for that care.
Right.
For that service. Yeah.
Understood.
So yes.
Okay. All right. Thank you.
So
does that answer your questions? Okay.
Yeah, that's a new service that would be available for people that, for instance, parents with whom an adult with SMI is living, or other caregivers like that, and it would be provided by the providers, by the Medicaid providers. Okay.
Yes.
All right, that's very helpful. And you all have always been very good about letting me know about public comment and so forth, and we will depend on that again, because I think there's so much interest, as you know, in this issue, and a lot of people have been, a lot of our BHTAC attendees and so forth will want to carefully look at this 1915I and give you their feedback. So thank you very much for that. So that's progress and a kind of a time frame. That's very exciting. We appreciate that, Jody and Jerry and Leslie and Angela.
We are excited too. It's a great opportunity for us to provide so much more. And even though it's kind of looking different than I think we all originally thought, but still going to be able to expand services in a comprehensive way, which is great.
Yeah, exactly. All right, very grateful for that. I don't know if anybody is on, Dr. Ali or anybody from the Medicaid formulary. We have an issue that has come up where, let me get my paperwork. This came after we were in Bowling Green talking about services, and a woman there sent me some information that there are a number of pharmacies in the Greenville area, Beachmont, who are now saying that they are no longer going to fill prescriptions for stimulant medications. And at first I thought it was connected only with an MAT clinic there called New Start. And they were the ones that were given this information, but it also is a primary care clinic there that's called Care Now. These are Walmart, Walgreens in Greenville and Madisonville, Hometown Pharmacy in Madisonville, Rice Drugs in Beaver Dam, Midtown Pharmacy in Beaver Dam, Yates Pharmacy in Russellville, Casey's Pharmacy in Hopkinsville, Tom's Pharmacy in Hopkinsville, and Main Street Pharmacy in Cadiz. And I guess my question is, how is it that these pharmacies can just decide that they're not going to fill prescriptions for a certain whole class of medications? I don't get it.
I don't see anyone on from pharmacy, so I'll take that back and see if I can get that answer to you for you.
All right. I will also follow up, Aaron, with a direct email to Dr. Ali, and I'll copy you so you have that information.
Okay, thank you.
Yeah, she typically, or somebody from formulary had typically been kind of monitoring our agenda, so I didn't think to send it to her ahead of time. But I will follow up with an email and copy you and probably Commissioner Lee and Deputy Commissioner Judy Cecil.
Okay, thank you. And I do send out the agenda to them. It's just probably with all the forums and all the events going on.
Yeah. But this is of great concern, and it's particularly concern to me as a psychologist because when I was in practice, I was doing those evaluations for, in my case, kids, but it's also adults who need psychostimulants for treatment of ADHD. And I just am very concerned about people not having access to appropriately prescribed medications that they need. And it sounds like it's, it's 7 or 8 pharmacies here that are affected. And 2 clinics, at least 1 MAT clinic and 1 primary care clinic. So I'll gather that together and send that along. Thank you, Aaron. We also had a question about changes in telehealth rules for IOP, partial hospitalization and outpatient behavioral health with the end of the federal emergency. And then I got a follow-up email from this person from Peace Hospital who said, oh, it's apparently only for Medicare beneficiaries that there were changes in telehealth rules. But it made him wonder and wanted me to ask, are there any changes anticipated for Medicaid members? So I can't remember whether he sent me exact wording. Has anybody from Medicaid heard anything about this, about changes in those particular services with regard to telehealth?
This is Leslie. I have not. If you want to forward that information to us, I can reach out. There hasn't been anything like specific to specific services. It's just been that there are no changes at this time, other than there might be some platform changes in August and audio versus audio and visual coming at the end of the year.
Okay, I will forward it to you. It came from, as I say, one of the leadership staff over at Peace Hospital, who was obviously concerned coming from a psych hospital with IOP and PHP and outpatient all being affected by this. Relieved that it was only Medicare, but it made him wonder if there were any implications for Medicaid. So I will send that to you, Leslie. Thank you. Nina has asked what were the changes for Medicare, and I don't remember, Nina. When I find the email, I'll also share it with you.
Sheila.
Yeah. So I'm hoping that we have nothing but good news about the bypass list for people that are dual eligible Medicaid and commercial insurance. And I hope that the bypass list has been made available. Do we have anyone that can report on that?
This is Herb with Humana. I can talk about that.
Great, thank you, Herb.
Yeah, so we, the department actually did share the bypass list along with the communication and the attestation form, I believe at the last TAC meeting. And so everybody should have that who attended that TAC. I also shared it with Steve and a few other BH providers, but so it is out there. All 6 MCOs are following the same bypass list. We haven't been able to post it yet on our website because it has to get approved by the department until we can. So that all the MCOs are waiting for the approval from the department on those documents so we can actually post them to our website. But okay, the department did share the same bypass list that we're going to post along with the attestation form and the general communication to the providers about how to use that bypass list. And it's a very general list. It's specific codes and 3 specific modifiers. So it's not based on provider types. It's not based on diagnosis codes. It's not
Okay.
based on blood type or anything. You submit the claim and it has that code on there or one of those three modifiers, then that claim line will bypass the need for commercial insurance, EOB.
Okay, Leslie or somebody from EMS, could somebody send that to me?
Yeah, I believe I did, but I'll take a look
Yeah,
at
and
that.
I
Let's get it out again,
apologize.
Sheila. And I think we shared, I don't have the list in front of me, but I'm pretty sure we shared on some listservs as well. It seems like Jonathan Scott may have sent out on several of the listservs. And then I think Aaron or Kelly, I think Kelly was here during that time. Kelly may have sent to all the TACs as well.
Yes,
Yeah.
and I apologize if I didn't, I may have gotten it, but it's not ringing a bell with me. And I sometimes get direct, emails from people saying, do you have this, whatever, and it's helpful for me to have it. So I would appreciate that.
I can go back and get that out and send it back to you.
Okay, that would be great. Thank you.
No problem.
Leslie, I don't think Leanne Fitzpatrick maybe is on. We have this.
Hold on,
follow-up.
Sheila. I just want to thank Herb Ellis for heading that up on the bypass list.
Yes.
We've been talking about it for a long time, and it really got busy in the last 6 to 9 months, maybe. And we have a product, so we're going to see how it works out and what happens. So we appreciate that, Herb.
No problem. Thank you for the
Yeah.
patience.
Yes, we do appreciate that. And we appreciate all of the MCOs cooperating with it and being a part of the process. Because obviously, like the credentialing, the more that everybody's on the same page, the easier it is for providers and payers, and certainly easier for our clients to get the services they need. So thank you very much.
You're welcome.
Thank you, Steve, for reminding me. Leslie, you may remember that Mary Haas brought up this issue at the last TAC meeting about her relative that was in a waiver, ABI waiver
Yes.
setting.
Yes.
And we had raised the question about whether anybody could intervene in that situation. And Leanne had volunteered that she was in touch with CMS around some of these, and there was some federal rule that said that there couldn't be an emergency intervention in a federally funded, I'm doing this from memory, so I may be way off base, but there was some glitch about that. And we asked her to pursue that because I know Mary would like to have an answer, because this, I'm sure her relative is not the only one that has encountered this problem.
Yeah, so Sheila, what CMS had said is that they wouldn't come to a facility that's currently being paid like a Medicaid facility. They actually consider waivers as a community residential, like that's their home. So we're going to double check, but if the last information I remember getting from CMS is going to allow us to cover the waiver members that are in residential, which would be the 2 ABI waivers and the SCL waiver. As far as I know, those should be covered. But I will go back and double check because we've not looked at this language for a little while. It's been a couple months, but if that's what I remember. So as long as they consider the waiver client in a community type of setting, which is considered their home, we should be able to do that. Now, we'll tell you, we'll have to develop some rules around providers, residential providers, about I don't want everybody to call a crisis line when some things could be handled by the provider, and we do expect some things to be taken care of. Now, I think Mary had mentioned things like hurting themselves or others, or a fight that's might have occurred between 2 members in a home. So we just need to take a look at those scenarios. But I believe CMS is going to allow us to cover the waiver members in community residential care.
All right, and let me ask Mary if she has any follow-up questions then.
Well, I think this is good. I mean, these crises happen. It's not just, someone I care about, but, I care about all the participants in the waivers. And I think if we can get some regulations or however way you think would be best, Leslie, but this will not just happen this one time. It's happened in the past. And, I also think we need to look more around neurobehavioral crisis stabilization, so it's a pretty big topic. And, so I appreciate your work on it so far, but I think it's multifaceted. Let me put it that way. So I think it's going to take some, work to hopefully get some type of stabilization, even, as far as the person who's the perpetrator, and then it's also the person who's the victim of the aggressive behavior and everything. So it's a lot, because the person who suffered the abuse is now undergoing counseling twice a week, just trying to deal with the victimization that she experienced. So anyway, I think it's multifaceted. So I appreciate you looking at it, but I think it's going to, I think providers don't know what to do in this situation. And, like I said, and no one wants someone to be kicked out of their home, but then in the other sense, the person needs to be kept safe. That's, being the victim. So.
Yeah, I think that's well said, Mary, because I think there's rights on both sides, but I think our first and basic is to make sure that everyone is safe.
Right. And the one, I have sympathy for the person who, is exhibiting the unwanted behaviors. And then also, like I said, the person's victim, now that person's undergoing, twice a week counseling, just trying to deal with, and she keeps saying, I didn't do anything wrong. And she's right, and so it's multifaceted. Let me put it that way.
Yeah. Okay. Yeah. Thank you, Leslie. I just remembered that Leanne had been on that discussion and had been in touch with CMS.
It's not a problem, and I'll continue to work on that, because we do need to know that comes up often. So we do need to know. And of course, I'm well familiar with the brain injury world, and so I do want to try to figure this out, that we can serve the most people we can. You've heard me say, anyone, anytime, and we want to make sure that we really can stand by that no wrong door. So we're working on it, but we'll probably have to have a few rules around it. If it's a residential provider that's getting paid, we'll have to have a few rules around it.
Yeah. Yeah. Thank you. Next item is a wrap up of the 2023 session, and I'm going to mention just a couple of things, and then I will follow up with a list in writing that you all can look at. We did a maternal mental health bill that I think will hopefully help address what we've always called postpartum depression. It's now actually called perinatal mood and anxiety disorders, or PMADS. And that was Senate Bill 135. It requires anyone who is attending the birth of a baby in whatever setting to provide information not only to the mom but also to family members. Interestingly, not only are women prone to these disorders, but the fathers are as well. And there's a correlation if there's already some mental health issues in the family, or if the mom is significantly impacted, the dad is likely to be as well. So we need to educate the entire family. There also is going to be a stakeholder group convened by the cabinet to look at training of more mental health professionals to treat perinatal mood and anxiety disorders. There really are not very many mental health providers, as well as the providers on the healthcare side, looking at support services. There are a number of services available in other states and in other countries, actually, for women to be able to identify symptoms. Most of the screening is actually done by pediatricians, because as those of us who have had babies remember, you go see your OB maybe one time after a birth, and then probably not for another year. And whereas you're seeing your pediatrician on a very regular basis during that postpartum period, when this, which is when the symptoms are likely to appear. And obviously, the bill that was passed the previous session to extend postpartum Medicaid coverage for 12 months is a huge step in the right direction. Senate Bill 47 authorizes medical cannabis for limited conditions. I think there are more questions than answers in this legislation. It's not effective for another year, January of 2025. And I think there will be further legislation in the 2024 session. But I think physicians, nurse practitioners, physician assistants who would be making these recommendations probably have lots and lots of questions about how this is going to happen and what the parameters are going to be. Senate Bill 94 will allow APRNs, advanced practice registered nurses, to continue prescribing controlled substances without having to have an agreement with a physician if they've had one for 4 years. We think that this will open up more APRN practices all over the state. They tend to stay in their local home communities, and we think there will be more access to healthcare and mental health care. There's a growing number of APRNs that are going back to school to get certified in psych mental health nursing, which I think is going to be a real plus. House Bill 21 will arranges for the homeless to get access to IDs, and particularly allows homeless youth, 16 and 17-year-olds. We know how important it is to be able to have a picture ID for various things, and this bill is going to allow that. It also establishes a rural housing trust fund. House Bill 148 should be of interest to all behavioral health providers, requires insurers to pay behavioral health out-of-network providers directly, as opposed to sending the payment to the policyholder, which had been the practice of many of them. So we think this will be a significant improvement for behavioral health providers. House Bill 200 is attempting to look at the healthcare workforce by providing more scholarships. There's opportunities to partner with this fund, particularly if you have a particular kind of provider that you want to see more of, or you're in a particularly underserved area. That's Representative Ken Fleming's bill. House Bill 248 attempts to regulate recovery housing for the protection of residents. Thanks to Steve for his work on this with Representative Hebron and others. This has been kind of the wild, wild west with recovery housing, and we think there are situations where people have been taken advantage of. So this is at least a small step in the direction of putting some regulations in there. An important piece on the SUD side was House Bill 353, which allows fentanyl test strips to be used. They had previously been determined to be drug paraphernalia, and so they were not available, and now they can be made available, and they will save lives. I don't think there's any doubt about that. House Bill 551, I'm not suggesting that we had a position on whether we wanted sports betting or not, but the significance of this is that after about 20 years of work, this is the first piece of legislation that actually puts funding in place for the prevention, education, and treatment of problem gambling. And this is a group, the Council for Problem Gambling, that has been working literally for 20 years on this. Mike Stone and Dennis Boyd, many of you will remember as a former commissioner, have worked on this tirelessly. So there's funding in that. And then House Joint Resolution 39 requires the cabinet to address the benefits cliff issue. And this is what happens when people make $1 over the Medicaid limit and then lose that that coverage. There's no slide down, if you will. They just fall over the cliff. And there's been talk in the last 2 to 3 sessions about creating some kind of slide down or some kind of handoff or some kind of other way to make sure that people get coverage without just abruptly ending their coverage. And then I was not aware, but John Copley mentioned SB 209, which really encourages that provider certification to be across all of the MCOs. We had a number of bills that were supported that didn't go anyplace. Bills to establish an all payers claims database, which I think would give us much needed information on where our healthcare dollars are being spent. A bill to provide insurance coverage for chronic pain treatments. Bill to exempt providers from prior authorizations if they have a good record with the insurer. Bill that's been there for several years to use a Mental Health Protection Act that would ban conversion. They call it therapy. It's actually, Senator Kerr says, conversion torture done by unscrupulous mental health professionals, actually, to try to convince kids through very negative means that they are not gay or whatever the situation is. There was also a bill to put an app on the phone of all Kentucky students where they could immediately text mental health help. That was again, a Representative Fleming bill, passed the House but didn't pass the Senate. On the ugly side, so that's kind of the good, the bad, and then the ugly. I think there are a lot of concerns about House Bill 3, which was the Juvenile Justice Reform Act. It's going to allow youth to be detained for 48 hours before they're ever evaluated, which is dangerous, I think, for kids when we don't know what their status is with regard to suicide and some other things. It also keeps them housed in an old building in Louisville that's not set up for mental health treatment. And it doesn't provide any additional funding for mental health needs. Senate Bill 65 ended a new program that the cabinet had begun for adults on Medicaid who would receive enhanced dental, vision, and hearing benefits. I guess the worst from my standpoint is Senate Bill 150, which cuts off access to gender transition medical services for trans kids and makes the schools much less a safe place for our trans students. And I'm very concerned that we're going to see an uptick in suicides among our trans youth. So I will send that out to you separately and you will have that information. Are there any recommendations for the MAC meeting in May from any of our voting members? All right.
Sheila, do we
yeah.
need one on targeted case management? I don't know if we need one, but there's a big topic of discussion today.
Yes. Let's do one just to put it on the record. Steve, what would you recommend? A clear policy statement from
Yes, a
DMS?
clear policy statement on targeted case management and as it relates to comprehensive plans of care or integrated plans of care.
Okay. So that's your motion that we recommend the DMS issue a clear policy statement on targeted case management as it relates to integrated plans of care.
Correct.
All right. Do we have a second from any of the voting members?
This is Eddie. I will second.
Eddie, thank you very much. So we have a motion and a second. All of those in favor of the motion signify by saying aye.
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 Aye. And opposed? And abstain. All right, we will make that recommendation.
Yeah.
Thank you very much.
And for me, it's to go on record with the MAC.
Yeah.
It doesn't necessarily, I know Leslie's going to work on it. Commissioner Craycraft's going to work on it. I just think we, as the TAC, need to go on record.
I think that's right, Steve. Thank you. We have a number of carryover items, some of which we hope will get resolved before our July 13th meeting. I don't believe there's been any updated prior authorization guidance. I don't think there's any change in that. Has there been any change with regard to the MCO audits? Steve's shaking his head no. Okay. All right. Our next MAC meeting, or the next MAC meeting is coming up in 2 weeks. That's May 25th at 10 a.m. And the Zoom link is on the DMS website, but I'll also send it out to everyone that I have email addresses for. And remember to email me at kyadvocacy@gmail.com if you want to get those updates from me. The next BH TAC meeting is July 13th. And we're back as we were today at the 1 to 3 timeframe. Is there any other business to come before the TAC? Let the record show that we're ending at the stroke of 3 o'clock at the appointed time. So I thank you all. I thank the voting members of the TAC for your participation, and for all of you who have participated. And certainly thank the DMS and DBH staff for all of your help. And Aaron, you and I can touch base on some follow-up items after the meeting. We welcome you back.
Thank you. It's great to be back.
All right. Thank you all very much. Enjoy the rest of the day, and we'll see you in 2 months. Thanks
Okay.
for being on.
Bye.
Goodbye.